Hi, and welcome everyone. Today's webinar is about how to increase choice and reduce costs in Part C plans. And I'm going to turn it over now to Melina Giannini, the CEO of ABC Coding Solutions.
Hello. I want to give you a bit of background about the company. We started ABC Coding Solutions in 1998 to overcome the technical issues that would be faced by non-physician practitioners trying to file claims to insurance companies. And 21 years later, we have a lot of information technology in place ready to do just that. I want to go to the next slide, please, Kelly. I got into this business because I used to design and sell self-funded medical plans to large employers. And part of doing that was negotiating for the administrative piece, the peer review, the reinsurance. So all of the component pieces of the insurance policy were something that I was familiar with, as well as reviewing data on a really consistent basis to make sure that my client, the employer, was getting the bang for his buck for his insurance premium, and he wasn't paying for things that were out of range for costs. So that is the background that I bring to this presentation. And I want to talk today about Part C plans or Medicare Advantage plans being able to invent and leverage success with CMS, because CMS approval of any process is going to reverberate throughout the industry. So I believe that any Medicare Advantage plan that wants to be a market leader in developing new ideas and plans that will save money to the government and their own plan over time is going to be best served by working with CMS. And right now, CMS has 5 models for innovation that it's getting close to the application date. It's coming up on April 16th. We're offering to help any organization apply to create a meaningful model and identify and overcome challenges, which we've thought about consistently over the last few months as to how that would happen. We want to tell you that we have been looking at CMS hot buttons for years, and we think that we could bring a lot of value to an application for any company that wants to work with us. Then at the end of the presentation, Kelly's going to tell you about how you can contact us. Next slide, please. So CMS is testing ways to improve access and care for seniors using value-based insurance design models. They have to find solutions to unsustainable costs because our economy is not doing really well, and it's only going to get worse over time because of the new stimulus packages. And we have to be able to reduce healthcare costs, because before the pandemic, they were consuming 21% of our gross domestic product. And now that we have all of the COVID issues on top of it, it's much higher than that. So it's imperative that the government find new ways to reduce the cost of senior care and then be able to trickle that down to Medicaid and TRICARE. Otherwise, the government's not going to be able to pay for health care insurance for us for long because they won't have the money. And when CMS develops something new, the rest of the industry adopts it. The reason they do that is because all of the insurance companies work with CMS, either with Medicare or Medicaid or TRICARE. So as goes CMS, so goes the rest of the industry. And I just want to stress that failure to solve rising healthcare costs is one of the greatest threats to our economy, and conversely, solving those problems would be a benefit to everyone. Next slide, please. So the CMS VBIDs, as they're known, acronym-wise, are designed to reduce Medicare costs, enhance the quality of care for seniors, improve coordination and efficiency of healthcare delivery, and use data to quantify costs and outcomes. Next slide. So what are the 5 models CMS is testing in 2022? Everyone that applies must have a wellness and healthcare planning services portion of their application. And so they have to include number 1 in their model design. And the flexible benefits are for the list below. I won't read them off to you, but just take a moment, please, and go over those, because those are the areas, pretty broad, where CMS is looking for new models of healthcare. Next slide, please, Kelly. The flexible beneficiary rebate is up to $600 per member. So they're looking at new ways to drive patients to better care using financial rebates as a motivator. And the same thing for Part C, Medicare Advantage, and Part D, the drug benefit. Again, up to $600 per member. And the 5th model that CMS is looking at is for Medicare hospice benefits. This presentation, we won't talk about that, but it's also a possibility. Please go to the next slide, Ms. Kelly. We envision building a model that will solve CMS's biggest problems. We can help you identify the greatest stresses on the U.S. healthcare delivery system, and we can help you create a model that other Part C plans can implement. That's going to be important to CMS, that it be replicatable. We need to show how to use data in the model that we would build. So we would benchmark existing data from your plan for whatever we're going to study. And then we'd extract data from existing business models by leveraging those. I'm going to talk more about that in a minute. We could collect data within 12 months that would allow CMS reporting within 6 months on the benefits, the cost benefits, and the efficacy of the model that we propose to build with a partner. Next slide, please. So we know that part of CMS's process in thinking about the wellness and healthcare planning is to also address end-of-life care, so that all of the members who do not want to be in the hospital at the end of their life or have surgeries to keep them alive, their wishes are met, which will also save money. And so we would approach this using nurse coaches to conduct wellness visits, document patients' care preferences, and that would include things like acupuncture versus medication for pain management, and to explain end-of-life care planning and provide the resources patients would need to create their advanced directives and other legal documents to assure that their end-of-life wishes are met. We could address socioeconomic issues. For example, that same nurse coach could be helping coordinate patient access to culturally competent care, such as Ayurveda for people from India, Oriental medicine for all of the Orientals in the country, and Native American healing for our Native American population. That is predicted to be something that will create better outcomes because the patient is more comfortable with that kind of care, but it really hasn't been measured in the United States. Chronically ill patients. We could use nurse coaches again to work towards explaining patients' executed end-of-life planning documents to the family way ahead of death, so that the experience of dying is gentle and kind to everyone involved. Next slide, please. We could also address care management programs. We recommend that any model we help design for a plan address chronic care, because everyone knows that 80% of seniors have at least one chronic care condition, and most of them have more than one. So let's lead right into high value providers from that. Thinking about chronic care and thinking about how patients might get better outcomes for chronic care treatments, we would like to test the benefits of letting the patient select any qualified provider to treat their pain or other chronic condition. And we believe there's no one more interested in reducing pain than the person who has it. So our planning would evolve around making sure the patient choice is not something like feel-good massages. We would not allow that to happen. But whenever somebody is dealing with something that's ongoing and chronic, if we can get them off of pain medications, that's a CMS goal. So we'd like to test using non-physician providers and no drugs to see if we can't get high-value providers to come forth and be able to address chronic pain conditions that we don't know about until we measure what happens. Again, disease management programs. We need to have a provider in between any group of non-physicians and the insurance company who can speak both languages. We recommend you use a holistic clinical nurse specialist to manage care alternatives within and without the company. And we have a plan on how that person can act to assure quality assurance. If you don't design your model to address the things that are going to happen after the care or before the care, to make sure it's managed well, it's not going to be something that's going to be sustainable. So we want to address what goes in to the planning and the claims review ahead of having a model, so that that's part of the model. We also want to do reductions in cost sharing for Part C benefits or Medicare Advantage benefits. So there's a logical $1,000 benefit would allow the insurance company to pay $600 of that benefit for chronic care delivery by alternative providers, and the patient would be responsible for $400 of that benefit. I believe that's going to really entice a lot of people out there who like to use alternative medicine to choose something that's gentle and less invasive and not drug-based. Next. We know that the business challenges are going to have to be overcome before any of this could happen. For example, there's a lack of codes to describe care alternatives. Even with the nurses, there's only 200 codes within the current coding system to describe care from over 2 million practitioners that aren't physicians and aren't working in a hospital. There's no RVUs for contracting, automating payments, or analyzing costs. And therefore, there's no best practices. So claims review is problematic. Excuse me. There's also variations in state scope of practice laws. Imagine there's 23 licensed healthcare provider types out there, and they have different laws in 50 states in the District of Columbia. So trying to understand what they're allowed to do is key, because if the insurance company doesn't do that, they could be liable for that HIPAA fraud and abuse fine of over $10,000 per line item, and so could the practitioner. So we have to deal with who's allowed to do what in which state in order to build a good model, and we can do that. So comparative effectiveness research is not possible without codes and RVUs, because the entire industry is using data based on those elements to determine what healthcare costs. Next slide, please. My company has been in business since 1998 working on these problems. We can facilitate contracting with codes and relative value units. We can train providers to file clean claims before they are ever filed to the insurance company and make sure they're only operating within their scope of practice. and we can establish claims review policies and procedures. We can help benchmark, collect, analyze, and report outcomes data. And with that data, we can develop comparative outcome studies. Thank you. Kelly?
I'm going to walk you through the website to show you how you can get in touch with us. But basically, you can schedule a consultation, or you can go to our website and review that to learn more about us. Or you can also email us directly, info@abccodes.com. So let me show you how to navigate the website. We provide solutions for PPO networks. You can go to our website here to learn more about what we provide for PPO networks, and also read some of what some of our clients are saying, some of our third-party endorsements. We also provide solutions and services for insurers, and you can also read about what our clients are saying here. If you'd like to schedule a 15-minute consultation with us, click the Call Us button at the top, and you can select a day and time to meet with us over the phone. We also have a Contact Us form. You can click on Contact Us if you prefer just to reach us via email. Fill out this form, click Send, and then we'll receive it and get back to you shortly. That concludes our webinar for today. Thank you so much for joining us. Thank you for joining us today. Visit us at www.abccodes.com and look for us on Facebook, Twitter, and LinkedIn.